C. difficile?
Is that C. difficile enterocolitis. I think that's something that bothers you, that you're all afraid of, so hopefully at the end of the session today, you'll understand about C. diff and that it won't frighten you and it won't frighten you to get a patient with it. Now, why don't you tell me what you know about C. diff? What do you know? What do you think it is?
Maybe fairness and colon is in it.
In the colon,
In the colon.
right. How about anybody else? You know why you're so afraid of it? Or are
Is
you?
it contagious?
Because it's very contagious.
It is?
No, I'm just repeating what you're saying.
Oh.
Well, last month we had, I think, 3 patients in the whole hospital that had C. difficile that we considered to be hospital acquired. The month before we had 2 patients that we considered to be hospital acquired. And the month before that, I think we had a few more, 5. The most we've ever had, I think, is 7. So from those figures a month, you can see that it's not very contagious. You know, right? Because if it were very contagious, you'd have 25, 50, 75 patients every month getting C. difficile. So what is it that makes only those few patients get C. difficile? Because you figure, you know, all the patients are in the bed in the hospital, maybe everybody's equal. Do you think everybody's equal in the sense that they could get C. difficile? No. Only certain people will get C. difficile. And usually, they're not the people who work here. But you can see later. We'll go through who gets C. difficile. In the second paragraph, we'll go through this one here that's dated 1995, December the 5th. The following recommendations apply to all personnel and patients. But the second paragraph tells you how you can identify the high-risk people who are high risk to get Clostridium difficile enterocolitis. Okay, and then we'll go into what it is after that. So who could get C. difficile? Elderly patients or any patient. It says here elderly, but it's any patient with altered bowel flora. And that means that any person who has anything the matter with their GI tract, from the mouth to the anus, anything the matter in there could get C. difficile. If you don't have anything the matter, its chances are you will never get C. difficile. So that's number 1. And the patients are patients with, I keep falling off the arms here, they're nice and slippery, and patients with Crohn's disease, pancreatitis, cancer of the bowel, liver disease, biliary obstruction, you see all those things? Gastritis, ileitis, colitis, diverticulitis, gastrostomy, bowel obstruction, anytime you have a patient with that, which you don't have too many of those, do you? Most of you have orthopedic patients. So you don't have too much C. difficile. That's the number 1 requirement. Patient has to have something the matter with their GI tract. Because C. difficile is spread fecal-oral route. That's not very appetizing. It's right after lunch. But what is fecal-oral? You must get the C. difficile into your mouth, into your intestine to become sick. It means you have to eat it. Right? So think about that one, and we'll talk about that a little bit later. She's shaking her head no, but that is, the mode of transmission is fecal-oral. You say fecal-oral, that sounds better than...
I don't know if it sounds better.
Which one? So, then it gets to your stomach. Now what happens when it gets to your stomach and your stomach and your stomach? You just eat regular food. You probably take vitamins. You don't have anything the matter with your GI tract. You have good stomach ulcers. You don't take any Tums. You don't take anything that alters your gastric juices, right? So what happens when C. diff gets to your stomach? It's killed. Because you're all healthy, and that's what the stomach does. It does that for a lot of things. That's why when you all go to eat at McDonald's, not everybody gets sick. The people who will get sick from GI diseases like this are the elderly who have not as much gastric juice anymore as they used to have. The babies, because they don't have very much to start with, and all the people with GI disease. Those are the people who will get very, very ill. The healthy young teenager, he might get ill, but he has to eat, 100 pieces of chicken, which they usually do. In other words, the inoculum for him, the amount has to be real big. Otherwise, he probably would not get sick. Okay, so you understand that one part of the picture. Now, the other part of the picture is something else has to happen to this patient. First, they have to have something the matter with their GI tract. Secondly, they have to get some C. difficile into their GI tract. That might be difficult. We'll talk a little bit later how you can do that, though. And what's the third thing? The third thing is they have to receive antibiotics. So if you only have one, if you have C. diff, you have a messed up GI tract, and no antibiotics, they're not going to get enterocolitis from C. diff. So you see how it all has to be in place for anybody to get Clostridium difficile enterocolitis. And the antibiotics, what they do is kill off all the good guys. Down in your gut, you got all this fight going on every day. Good guys and the bad guys, and usually the good guys take over. But when you get antibiotics, that alters, and some of the good guys are killed by the antibiotics that you take, and allows the C. difficile to emerge the victor, and he takes over, and then causes the patient to become ill. So the third thing is that you have to have antibiotics. Okay? So if you alter any one of those three things, then your patients are not going to get enterocolitis from C. difficile. So how can we alter? The first thing is we might not be able to alter what's the matter with the patient. The GI tract, they got something the matter. Maybe half their stomach's gone because of cancer. They're coming in for colitis or ileitis. You really can't alter any of that, can you? There's nothing you can do or I can do about changing that. So we're going to have to leave that alone. So the second thing is you can alter the patient eating it. That you can change, can't you? Now, where do you think it sits, and how do you think he eats it? Or how do you think it gets into his mouth? Clostridium difficile, or Clostridium, the family of Clostridium the family name is Clostridium. Other kids in that family are called Clostridium tetani. You know that kid? That's the one that causes tetanus. So if you cut yourself on a rusty nail, or if you're in your backyard, you have to get a tetanus shot, don't you? Why is that? Because the tetanus lives in the backyard, and it lives on the nail. So that means that there's no way that you can go through with Lysol or something and clean it off. It lives forever, in fact, in your backyard. So that's one, and then there's Clostridium botulinum, another kid. That causes botulism, with food poisoning. Mm-hmm. Your grandmothers used to, know about that. Clostridium perfringens, gas gangrene, another old type thing we don't really worry about much anymore. But sometimes when you see patients come in with gangrene underfoot and all, you might, be thinking of that. So for all the Clostridium that you already know about, one thing they have in common is it lives forever. I mean, there's nothing you can pretty much do. In fact, if you cultured that chair there, I bet you'd find some type of Clostridium. It's difficult to eradicate. Like AIDS. How can you get rid of the AIDS virus? Just scrub, scrub, scrub. Even just bleach will kill the AIDS virus, which it cannot live outside of a person for very long. You can't get AIDS by touching something, but you can get C. difficile because Clostridium survives in the environment. So that's the clue. That's how to protect the patient from it. Because probably it's on the bed rails, the doorknobs, the walls, and one other thing which may or may not be significant, all of our recent patients, all of the recent patients with C. difficile have one other thing in common. It might not be significant. They all get oxygen with that little thing that you stick in your nose. And I have a feeling that that oxygen thing comes off and is thrown in the bed, and maybe it's hanging on the side rails, and then it goes back in their nose, which is interesting. I don't know what it means yet, but it's just an interesting way. It is a way, isn't it, that could go, get into them. So if you have a patient with C. difficile or any type of diarrhea or anything, you have to make sure the housekeeping cleans the room. And that means the bed rails, the walls, not the walls, but the doorknobs, the toilet seats, anything the patient has. The other thing is, before the patients eat, because maybe they have been touching the bed rails, maybe you can't do anything about that. Make sure their hands are clean before they eat. Just like you would a little kid, because you can picture they're sitting in this bed surrounded by, maybe the bed's got C. diff on it, maybe the side rails do. So that's one thing that you can alter, is how it gets into the patient. And it's truly by cleanliness. The third thing that you have to have is antibiotics, and there's nothing we can do about that. Because if the doctor wants the patient to have antibiotics, he's going to order them. The only thing that we have to change the picture of Clostridium difficile is the second one, and that's the cleanliness part. We have done a few things over time. We used to get a lot more C. difficile than we get now, and some studies have linked C. difficile to those electronic thermometers that we used to use. Hopefully you're using the ear thermometer. And the ear thermometer, you can see the difference between the two, can't you? Where you used to be putting their mouth, it would probably lay on everybody's bed. Can't you picture it? And then be put in their mouth. So those electronic thermometers were linked to C. difficile being passed from one patient to the other. And then cleanliness. But watch the oxygen things. You don't have many patients here with oxygen, do you? But
We have two right now.
right now, but watch that little thing. I don't know what that means, but it might be something like the electronic thermometer. Maybe it's something that's hooked somewhere or something and gets C. diff on it, and then it's, to me, extremely unusual. I keep thinking, well, this month I got 4 patients. One of them's not going to get oxygen therapy, but they all do. It's interesting, but in order to prove anything, you have to go and get another whole set of patients, and it seems like almost everybody that comes into Sibley gets oxygen, so, so it could be that that's just, doesn't mean very much, okay? So, these are the recommendations that we put out for preventing Clostridium difficile spread among patients. Let me go back to yourself. Do you understand how you are not very susceptible to C. diff? First place, you have nothing wrong with your gut. Second place, you're not getting antibiotics. And third place, hopefully, you always wash your hands before you ever put them near your mouth. Because it doesn't matter what's from the neck down. If you always wash your hands and always keep clean before you eat anything or touch your mouth or touch your nose or eyes, you're not going to get Clostridium difficile. Okay? So before you go downstairs, wash your hands. And then when you wash your hands, you say, oh my, I'm going to worry. What if I don't get all the C. difficile that's on my hands? What if I can't get it all off? Well, you have a tiny, tiny bit there. Well, then what? Your stomach probably will take care of that because you're healthy. Not so the patient with the messed up stomach, but you yourself. So we have had employees with C. difficile, but none of them got it from working with the patient. They all got it in the usual way. They were patients themselves. So they were in the hospital, got all these things, came out with C. diff. And then, of course, we did have to restrict them from work.
What if you had bowel manipulation?
Then I would be, if you have had bowel manipulation of some type, whatever, then I would be extremely careful if I were an employee when I took care of patients with C. diff. And not only C. diff though, by the way, all enteric diseases. People with any type of manipulation of the GI tract are susceptible to all enteric diseases. And especially if they don't have any gastric juices in their stomach. They have had cancer of the stomach and half their stomach is removed, or they're taking peptic ulcer medication or whatever. They are very susceptible to enteric diseases. Not only Clostridium difficile. And if there is such a person like that, they probably should come over to us, to Employee Health, and talk about it. You know, and we can help them. Well, no, you wouldn't be restricted from working, but it would help you. There are other diseases like that. People who are pregnant probably should come over to Employee Health, and they can be told, you know, how they can reduce their risk of infection. Okay? Anyway, so these are the recommendations. Hand washing before and after each patient contact. And that's so that you have a patient with C. difficile, that you don't then take it to the next person. Hand washing after each contaminated procedure on the same patient. Sometimes I see people, they change a Foley catheter, say, and then they take off their gloves and then they don't wash their hands. At that point, they just go on taking care of the patient, and maybe now they're going to brush the patient's teeth. But can you see that between those two procedures that you need to wash your hands on the same patient? Maybe you have to do it 3 times on the same patient. But if you just picture yourself at home, that's what you would do at home. I think sometimes that's something that we forget. Empty a bedpan, you use gloves. Pull a catheter, you use gloves, take the gloves off, and then just continue working without washing your hands, you know, at that point. Hand washing before initiating a clean or sterile procedure. Another thing, what it used to be that all of our patients, maybe about 2 or 3 years ago, that many of the patients with C. difficile were also getting tube feedings. Now we don't have that at all anymore. None of our patients with C. difficile are getting tube feedings at this time. So whatever we're doing, we're protecting them. But remember when it was all open and we just poured the stuff in and maybe people weren't too careful? The tube feedings now I think are like IVs, aren't they? Sealed. Yes. So no C. difficile can get into them at all. But before you do a tube feeding or anything like that, or suctioning or anything in the mouth, you should wash your hands. And make sure your hands are just as though you would wash your own hands before you touch your mouth. You have to wash your hands before you touch a patient's mouth. We seem to wash our hands, we think about it after we touch the patient's mouth, but you have to remember to do it before you touch their mouth. And enteric precautions for all patients suspected of having enterocolitis. And that's just really universal precautions. You know, washing your hands and whatever. If you think the patient has some type of colitis, to be real careful. And then teach and help the patients to wash their hands. And you can get those, if it's difficult to wash their hands, those towelettes, they're very good. You can use those. Some of them are bigger than others. I like the ones that are a little bit bigger because they do a better job. And then call housekeeping and watch housekeeping for all obvious soil on the floor. If you see soil anywhere, you know, to call housekeeping, feces or whatever, or if you don't think that side rails have been cleaned. So call housekeeping and tell them that you need that cleaned extra elbow grease put into it in order to clean it, okay? And then stay there with housekeeping and make sure that it's all clean. And if ever you have an empty room, if the patient goes home, you should get housekeeping to really clean that room really well. And once the patient's out, get housekeeping. Not just a little lick and a promise, you know, which is sometimes what it gets. Especially if you're trying to hurry the housekeeping department, they'll go fast for you. And then attention to the inanimate environment. That thing over there, what is that there, by the way? That little cart.
It's the therapist car.
Huh?
It's for the therapist.
They teach
They
the
teach
persons
them.
how to get in and out of their car.
Okay, but you see how that could be? You understand? So anything in the environment like that, that looks kind of neat, you try. But you see the handle there? You see, maybe patient had feces on their hands and come in here, learn how to do that. And maybe that's something that we would never think to clean. So to watch the inanimate environment like that, wherever people are touching, and for you it doesn't matter, kind of does it, because you can touch it all you want, because before you go eat, you're gonna wash your hands. Sometimes maybe the patients aren't, and they're assuming that everything is clean. So the inanimate environment, you have to watch everything all around, and then you don't have to clean it yourself, but just get housekeeping. Tell them, I don't think this has been cleaned. Remember that housekeeping are experts on cleaning, you know, and they know how to clean. And scrub the elbow grease is probably the best thing.
Station.
Huh?
Is it our job to tell housekeeping or is it therapist?
Yours, I think, because you own that. It sits up here. It's in your space. But if you ask them really nice, or ask your head nurse, you know, maybe the head nurse will ask them.
Okay.
What do you say, Patty?
I would take it upon myself to ask them to clean it, and I don't know how often it's used and who's using it.
It's used just about every day.
Just about every day. Maybe there would be clean.
Therapy can't clean it, because they don't know how to clean. Physical therapy, they know how to teach people to get in and out of that car, and how to walk, and how to, you know what I'm saying, but they're not cleaners.
Margaret, what do you recommend using?
Whatever housekeeping uses is good. But see, you're not cleaners either. You're real good at taking care of patients. And yeah, but you're not good at cleaning. And the housekeeping department is not good at taking care of patients like you are, but they're good at cleaning.
Yeah,
So you have to have the person that's good at it do it. So it's always housekeeping.
That's true, but they'll take offense on us telling them how to do their job
Well,
or
just
what
ask
to do.
them. Or if you could ask the head nurse or ask, and they could do it for you. If you don't feel confident, you know, if you think you're gonna make them mad, well then don't ask them, then ask somebody else. I bet she knows how to ask. Huh?
Well, I would go through the supervisors, that's what I.
Yeah, the head, yeah, who's ever in charge that day.
Elena would take offense.
You don't think? I don't think so either.
If we just bring it to her attention.
If you tell her, you don't think this has been cleaned,
Margaret, how often do you recommend cleaning something like this then?
well, I would say once a week.
Oh.
I mean, it doesn't have to be clean, but it's kind of like the thing that sits in the middle of everybody, and yet nobody thinks about cleaning. You know what I'm saying?
Right.
Yeah, it just looked, I just saw it there, and I thought that's kind of a good example. Something, well, what is it on this department, in this department that's giving us CDIFF, and it's something you don't even
Can
think
you
about.
imagine the folks who ride public transportation holding
Yeah.
onto those rails?
Yeah, but see, we all do that every day, but the trick is, when we go home, before we eat, we wash our hands.
Yeah, that I bet half the population don't do that. Just go home and eat.
Well, they might not wash their hands, but then they don't get any antibiotics. So they don't get C. diff anyway. And then a special attention to laundry collection. I don't think that's a problem here. We collect all the laundry the same way, in a bag, and it says soiled linen on it, so there's no problem. Tube feedings, we haven't had a problem with tube feedings, knock on wood, a couple years now. No infections from tube feedings that we can see. And just a reminder to all, tube feedings are like the patient's mouth. We don't think of it that way, but before you do any type of tube feeding, you have to wash your hands. And then stool specimens should be sent to the laboratory immediately for accurate results. You get a stool specimen that sits around for 4 hours, take it to the lab, it comes back and it says Clostridium difficile negative because it's been sitting around for 4 hours, and then that patient isn't isolated. You see what I'm saying? Although if you think about it, theoretically, no patient should really have to be isolated for for C. diff, because we're talking about feces here, right? I mean, you're gonna do something different with the feces in this room versus this room? No, because we don't do anything with feces, right? And so, if you think about it, we shouldn't have to even isolate for Clostridium difficile. It should be the same for all patients, but
So if they have
human
C. diff,
nature.
they should be able to go down to the dining room and eat with the other patients. They shouldn't have to stand
It,
there.
unless they have diarrhea and they're incontinent. If they're incontinent and have diarrhea, I would say they shouldn't go down there. But if they're not, they probably could. If they're not, if they don't have diarrhea anymore though, I suspect they don't have C. diff anymore. And so you could probably send some specimens, get some negative specimens and take them off isolation. But just remember that it seems to be that once you get C. diff, and maybe you'll come off your antibiotics and maybe you'll be cleared up, but then it seems to come back. So you gotta watch those patients. Don't assume that they're just all better just because you got one negative stool. Now, a negative stool doesn't mean an absence of disease. A negative stool could mean that you didn't capture the disease in that little tiny specimen you got. See what I'm saying? Always that's true of any culture. Doesn't mean they don't have disease, it just means maybe you didn't catch it and send it to the lab, or maybe it didn't grow or whatever. So I would look at the patient. If they have diarrhea, I don't think I'd let them go down. Or if they're incontinent, they shouldn't go. Okay? That's it. You think you know more about C. diff now than... No? You don't know? How about you?
I know more about it.
I have a question.
Yeah.
Since you said it can be coming back, recurrent again,
Recurrent.
that means there's no sure that it can be cured totally, right?
Well, most patients do get cured totally. If they don't have diarrhea, they're considered to be cured. If they don't have any symptoms, you know, they're considered to be cured. But every once in a while, we do get we readmit a patient with C. difficile.
So the
And we've had
symptoms
before.
is just diarrhea.
Right, right. Uh-huh. Hopefully you won't worry so much about it. And also, can you see where you could take a patient up here with C. diff easily? It's not going to happen very often because your patients are more orthopedic patients. But every once in a while you might be asked to take a patient with C. diff, and I don't think it's the worst thing in the world. Maybe none of the rest of your patients are even susceptible.
We already had 2 patients up there with C. diff.
I know you've had, one of them was questionable, maybe they had it when they came here. And then one patient, the other patient did come here with it, right? Yeah. But on the other floors, it's kind of all over.
Yeah.
You don't have to worry too much. Okay? Next time we talk about something that's worse, and that's vancomycin-resistant enterococcus, called VRE. You've heard that. And I know you've been asked to take patients with VRE. I think you can take a patient with C. diff and handle it very well. But I'm not sure about VRE. We'd have to talk about that one. But I think you should know what it is. It's a bacteria that is resistant to all antibiotics. And if the patient gets it, they die because there's no antibiotic to treat them. Newspapers and TV's been saying that's going to happen, right? And that's happening with, it's called vancomycin-resistant enterococcus. So, all right?
Okay,
So-
thank you. Do you have another question?
Yeah,
Go
so
ahead.
the C. diff, you can't die out of it, right?
No.
Okay.
Now, wait a minute. Now you're going to turn around and die on me. And we got this on film and everything. If you are, of course, 98 years old and really debilitated and, you know, and you get C. diff, it might do you in. But most patients do not die.
Die out of it.
okay? And no employees die.
Does anybody have any other questions for Margaret?
They get dehydrated out there.
Yeah, they do, because they put out so much fluid with the diarrhea. Right.
Okay.
Okay, thank you very much, Margaret.
Thanks.
Okay. That eliminates part of the matter.
I need for you all to
Yeah,
fill out an
don't,
evaluation form.
Watch what you eat, especially at Christmas time, with all those boxes of open chocolates in
Oh,
there.
yes.
You know?
Yeah.
Right.
That chocolate.
Not chocolate, not cookies, or, you know.
Great.
Toss them. I take them, but I toss them once I leave the room.
If you, if they give you something, we're not on TV now, are we?
No, it's off.
Just take the whole box out and open it out at the desk. And then you have to depend on your coworkers, so. I don't know.
But if you give them for the whole